Hey everyone, and welcome. Today we are diving deep into a topic that is, no joke, one of the most important skills you will ever learn as a nurse: delegation and supervision. Seriously, mastering this is not just about crushing the NCLEX, it's about keeping your patients safe and leading your team effectively out on the floor. All right, let's get into it.
So here's how we're going to break it all down. First, we'll build our foundation with the core concepts. Then, we'll walk through the critical thinking you need to do before you delegate. After that, we'll hit the holy grail, the 5 rights playbook. From there, we'll look at who does what, and then we're going to put it all to the test with some NCLEX questions and a real-world scenario. Sound good? Let's go.
Okay, first things first. Before we can even think about delegating tasks, we've got to be on the same page. We need to speak the same language and really understand who the key players are on our team. This is the bedrock for everything else we're going to talk about. Now, take a good look at these two definitions, especially that top one. Delegation means you're handing off the doing of a task, but, and this is everything, you are keeping the accountability for how it turns out. That never leaves you. It doesn't matter who physically does it, the outcome is on you, the RN. Supervision? Well, that's how you make sure it gets done right. It's the directing, the monitoring, the follow-up. So who exactly are we talking about on the team? Well, you've got your licensed folks, other RNs and PNs, and you have your unlicensed assistive personnel, or AUPs. The big difference? Licensed personnel went through a formal program, passed a huge exam, and have a legally defined scope of practice. As the RN, you're at the top of this pyramid. You can delegate to pretty much everyone below you. Understanding that flow is absolutely crucial.
All right, let's move on to what I like to call the critical thinking checkpoint. This is that moment where you need to hit the pause button. Before you hand off any task, you need to run through a quick mental checklist to make sure it's the right move for your patient. And here is that checklist. You have to ask yourself these questions every single time. Is this a routine task? Like, have we done this a million times with a predictable result? How stable is my patient? Is there a big risk for something to go wrong? Does this task need a nurse's brain, that problem-solving skill? And of course, does the person I'm giving this to actually know how to do it? And is it even legal for them to do it? You can't just pick one. You've got to weigh them all together for every decision. Okay, everybody lean in for this next part. If you remember one thing from this whole explainer, make it this: the 5 rights of delegation. This is your playbook. This is your guide. For the NCLEX, this is your ultimate memory anchor. Here they are: right task, right circumstance, right person, right direction and communication, and right supervision and evaluation. This is not a suggestion box, okay? It's a non-negotiable checklist. For a delegation to be safe and correct, it has to hit all 5 of these points every single time. Let's break them down one by one. First up, the right task. Look at the difference here. Helping with a bedpan? That's routine. It's predictable. A nebulizer treatment? Whoa, that's a whole different ballgame. That involves a medication. You have to assess the patient before and after. That takes clinical judgment. So here's the rule. If it's part of the core immersion process, assessment, analysis, evaluation, you cannot delegate it to an AP, period. Next, right circumstance. This one is all about one thing: patient stability. If you've got a post-op client who's stable, predictable, yeah, having the AP grab a set of vitals is perfect. But a client who was so unstable they just needed naloxone to help them breathe? No way. That client is a wild card. They need a nurse's eyes on them constantly. Stability is the magic word here. And the slide perfectly shows us the right person. An enteral feeding is not a simple task. It's a complex skill. It's well within the training and scope of a PN. But an AP? Nope, it is absolutely outside their job description. You have to know what's in your team's toolbox, what they're trained on, what they're good at, and what they're legally allowed to do. Now, let's talk about right direction and communication. Just look at the difference. Morning hygiene. What does that even mean? A quick face wash? Brushing teeth? But a shower before 9 a.m.? That is crystal clear. There is no room for error. Remember this: vague instructions are unsafe instructions. Your directions have to be clear, concise, and complete. And finally, we land on right supervision and evaluation. This brings us back to that golden rule of nursing: assess before you address. You simply cannot delegate a task like walking a patient until you, the RN, have laid eyes on them, done your assessment, and decided they are stable enough to do it. Your supervision starts before the task even begins by making sure it's safe in the first place. Okay, so we've hammered out the theory. Now let's make it super practical. Think of this next slide as your quick and dirty cheat sheet for who typically does what on the unit. You can see the pattern pretty clearly here, right? Look at the PN column. It's more complex, more technical stuff.
trach care, suctioning, checking tube patency, things that require a licensed skill set. Now look at the AP column. This is the foundational hands-on care. Activities of daily living, or ADLs, for our stable patients. This is a great table to study from to really get those patterns down.
All right, let's switch gears. Put your NCLEX hat on. It's time to see how all this stuff actually shows up on the exam. We're going to apply everything we just covered to see if we can get these questions right. Let's put that knowledge to the test.
Okay, let's break this down. What are the keywords? Admitted from the PACU. That should be a huge red flag. A patient fresh from surgery is complex, they're potentially unstable, and they need a deep, comprehensive, head-to-toe admission assessment. So, who's the only person on this list qualified to do that? You got it, the registered nurse. The answer is B.
Okay, a select all that apply. This is a classic test of right direction in communication. Let's go one by one. Does the AP need to know about the roommate? Nope, irrelevant. How about the slippers and the walker? Absolutely, that's a safety issue. So B and C are in. What about the pain meds? For sure, that could make the patient dizzy or unsteady. That's D. The allergy to codeine? Not directly relevant to the task of walking right now. So the correct answers here are B, C, and D.
So before we jump into our last scenario, let's lock this in. These are your memory anchors for test day. The 5 rights are your law. If a delegation breaks even one, it's the wrong answer. Remember what you can never delegate: assessment, education, or judgment. Patient stability is everything, and at the end of the day, you, the RN, are still accountable. All right, for our grand finale, we're going to tackle a short scenario that really tests your clinical judgment in the moment. This is exactly what the next generation NCLEX is all about. So it's time to decide. What's your move? Okay, so picture this. Your AP did their job perfectly. You delegated a task, they did it, and they reported an abnormal finding straight back to you. This is the system working just like it should. But now, the ball is right back in your court. The patient's condition has changed. So, what do you do? What is your next best action? The AP has handed you the data, but the task of figuring out what it means and what to do about it, that falls right on your shoulders as the RN. This is where clinical judgment kicks in, and it always starts with that very first step of the nursing process. So what's your move?